Robot-assisted laparoscopic partial adrenalectomy for pheochromocytoma, the National Cancer Institute technique. Adrenal pheochromocytomas arise from the adrenal medulla. Patients are often symptomatic due to catecholamine secretion by these tumors. Laparoscopic adrenalectomy has become the standard of care. There are numerous threats from a variety of pathological processes to the remaining adrenal tissue. In addition, patients with hereditary cancer syndromes may develop recurrent multifocal pheochromocytoma. Adrenal pheochromocytomas are located centrally and deep within the adrenal medulla. The cortex is not usually involved by tumor, and these tumors are well demarcated. These anatomical considerations have led to our interest in partial adrenalectomy. A recent review from our institution shows that while the number of cases of partial adrenalectomy has been increasing in recent years, its overall utilization for pheochromocytoma is low. In another report from our institution, we examined those patients with von Hippel-Lindau disease and associated pheochromocytoma who had at least 5 years of follow-up after partial adrenalectomy. We found that approximately 90% Based on our favorable intermediate and long-term outcomes using partial adrenalectomy for pheochromocytoma, we aim here to describe Pheochromocytoma was diagnosed by radiographic and biochemical abnormality. Previous abdominal surgery, a solitary adrenal gland, or multiple adrenal masses did not exclude patients. We present here the case of a 25-year-old female with von Hippel-Lindau disease who presented for the evaluation of palpitations. She had no prior surgical history and no kidney lesions. She was 5 foot 9 inches tall and 300 pounds for a BMI of 44.3. CT scan reveals a retrocavally located pheochromocytoma high in the right upper retroperitoneum at the level of the celiac axis. Adjacent to the pheochromocytoma tissue, normal adrenal can be seen. An adrenergic blockade regimen is instituted, with 2 weeks of preoperative blockade. Phenoxybenzamine 10 milligrams daily, as well as metyrosine 250 milligrams 3 times daily is used. 2 technical modifications are employed. First, the robotic ports are rotated more laterally and more superiorly. Second, the patient is rotated to an extreme flank position to better expose the upper retroperitoneum. In this obese patient, the ports are shifted even more laterally in cephalad. The triangular ligament is divided to facilitate superior exposure. A locking grasper is used to maintain superior retraction on the liver. The lateral border of the inferior vena cava is identified. The peritoneum is then incised, facilitating superior exposure of the liver. Note that no bowel mobilization is necessary. With the liver mobilized, the locking grasper is replaced more superiorly to consolidate the retraction. The adrenal vein is identified, emanating from the posterior vena cava. It is controlled with locking clips and divided. Laparoscopic ultrasound identifies the mass. Enhanced visualization and meticulous surgical technique allows one to demonstrate the difference between the tumor tissue and the normal adrenal tissue. A plane of dissection is established. The tumor tissue is dissected away from the underlying adrenal cortical tissue. The articulating instruments allow minimal handling of the adjacent adrenal cortex. This helps to preserve the adrenal blood supply. We work to maximize the preservation of normal adrenal tissue, which is especially important in cases with multifocal masses. Inspection of the resection bed shows no residual mass, good hemostasis, and a large amount of preserved normal adrenal cortex. No residual mass is identified with a laparoscopic ultrasound. Postoperative CT scan shows no evidence for residual mass and good preservation of a normal adrenal limb. We have performed our technique in a total of 15 procedures in 12 patients. 4 procedures were performed for multifocal lesions, and 4 procedures were performed in a solitary adrenal gland. Our perioperative and functional outcomes are listed below. 1 patient required a blood transfusion, and 1 patient required a conversion to an open procedure. There have been no cases of recurrence in this series. 1 patient has required steroid replacement postoperatively. This patient with von Hippel-Lindau disease had multiple tumors in a solitary adrenal gland. Our technique requires precise dissection between normal cortical tissue and pheochromocytoma tissue. Robotic assistance with articulated instruments allows for minimal manipulation of normal adrenal tissue, which maximizes the preservation of blood supply to the normal adrenal during the operation. Our technique for robotic-assisted partial adrenalectomy allows for excellent early functional and oncologic outcomes in pheochromocytoma. The technique can be used for a solitary adrenal gland as well as for multifocal pheochromocytoma.